Hi there, welcome to Ask the Chiropractor, your source for ultimate health, healing, chiropractic, and medical related information. I'm Dr. Adam Rodnick, a chiropractor out of Commerce Township, and I'll be your host today. We have two special guests. We have Mr. Bob Willard and Mr. Noman Siddiqui, and they're from the Knee Institute. Thank you guys for joining us today.
Well, thank you for inviting us.
Absolutely.
We really appreciate the opportunity to share our information with the public and to try to assist them in having better care for themselves.
Absolutely. And so we talked a little bit before the show about what you guys do and what the Knee Institute is, and I'm very impressed with the concept in general. You know, total knee replacements are becoming more and more common now as our population starts to age. As the baby boomers are getting older, these procedures are happening so often now. And so you guys have come up with another alternative to potentially prevent total knee replacements. And you guys do that through the Knee Institute, which is becoming a national organization, correct?
Yes, in many ways you're correct. We are affiliated with the Osteoarthritis Centers of America. There are only 100 in the United States, and we are the only accredited facility in the state of Michigan. And as our aging process takes place in our population, better known as the baby boomers, we find that we begin to have difficulty in all of our joints. We are concentrating on knees at the moment, and in the very near future we will also be concentrating on shoulders and hips as it affects all of us there. What we find is that surgery is not necessarily the alternative, as well as drugs are not the alternative. And in chiropractic care, that is one of the most exciting things that is available to us as patients, because you stress the balance of the body and not taking drugs and not getting surgery when it's totally unnecessary and many times. But however, I would like to point out that it is important to keep in mind that surgery is necessary in certain situations and not all. Today we hear all about the new implants that are available for knee surgery. We hear more of it because the population is growing to such a point that the pain and the mobility that is diminished is significant to that population. So we're looking for alternatives. Knee replacements have been very, very popular, but now they're starting to go in a different popular area. If you watch the attorneys that are on TV now, you will see that they are starting to present themselves as representing people out there who have had failed knee surgery and implants. The information that we used to receive was that knee implants and surgeries would last 15 years. The statistics are now proving that that's not the case. We are now finding patients having difficulty within 3 years. We're finding knee replacements failing within 3 years there. So it is a significant challenge out there as we go through this aging process, and I am one of them. I will be 72 years old in several weeks,
right.
Okay? And I have just gone through one of our procedures, and one of the problems that we have as senior citizens, number one, is simply getting out of a chair. I recently was in Jamaica, and I was in the plane, very excited, just like everybody else, to be on vacation there. And as the plane landed, everybody was moving very quickly and very rapidly so they could get their luggage and get on to their vacations. Meanwhile, I'm sitting there trying to get out of the chair with most difficulty, and it was really hard. The other problem that I would have that you find that this population has is going up and down stairs. And believe it or not, going downstairs is more difficult than going upstairs there. And it got to the point where I was holding on to two railings and literally going sideways so that I could get down to avoid the pain and create some mobility. Since I have experienced the process, which we will talk about as we go along here, I no longer have that difficulty. I am now doing exercises with the assistance of a physical therapy where I am getting in and out of a chair with two 20-pound weights in my hand like this, and I am now doing 3 sets of 40. When as recently as about 8 weeks ago, I couldn't hardly get out of a chair. So this is very exciting what we're doing there, but we don't want to diminish our orthopedic surgeons that do surgery, because there are places where it is totally necessary.
Absolutely, and I always tell our patients, you know, it doesn't hurt to go through this protocol. Start with conservative natural first, drug second, surgery last. I send a lot of patients out for orthopedic surgery, for neurosurgery, for spine surgery, and these patients need this, and it's going to help them.
No, go ahead.
I always start with that order,
Exactly.
conservative drugs, then surgery.
Well, I think that we can continue this conversation real quick here. If I can just take a couple seconds and take you through the protocol that we use, and we follow the protocol of the Osteoarthritis Centers of America, which is extremely factually involved and published papers all along. They have gone through 10,000 patients with 86.6% success without surgery or without drugs. And we are a part of that success. What is this process? And let me just give you a quick overview of it, and then Mr. Siddiqui, who is by far one of the best PTs that I have ever been involved with, and I've been in healthcare for 50 years, can explain a little bit more of it. But what we find is it's much more, but it's primarily a three-phase protocol here. One, after they come in and get a significantly detailed evaluation so we can know exactly what their problem is, where it is, and we do that by starting off asking for them to go to receive an x-ray, as you do in your office, or bring one within 6 months so we can see what's going on there. If it looks like there's a potential of osteoarthritis, and for the sake of ease, we'll call it OA, then they will be sent out for an MRI. And then when that comes back, we can, in great depth and detail, decide exactly what their problem is. Generally speaking, we put them through a process of PT, and physical therapy is very important. And we start that before anything else because these people have been so immobile that they literally have lost a major portion of their strength.
And one thing I see in general is for seniors, the more immobile they get, immediately their mortality is much more susceptible.
You're right, and
so this is the same.
You're
with,
right.
With
You're
hip
right,
fractures.
and the mortality even goes higher because there's a behavioral factor in there, and they become depressed. And part of the other problem with knees is weight. So when we're depressed, we eat much more than we normally would. We gain weight, and that extra weight creates a significant amount of trauma on those knees. The second thing we do is we utilize injections. You will find physical medicine doctors as well as orthopedics may be doing this, and they blindly put the injection into the knee. We have what we call fluoroscopy, and it's an imaging process to where the doctor can see exactly in real time where that injection is going. If it's off a little bit, then he can readjust to get in there.
It's very cool technology. And fluoroscopy, for our audience, it's essentially a live stream video of an x-ray. Something we have in our office that we do on all of our patients is a digital motion x-ray, so it's recorded. I can take a 2-second recording. Mm-hmm. What they're doing is a live video where they can actually see into the joint, so it's much more specific, much more exact.
And let me talk about the injections, and I'll let you in.
No, you go ahead. You're doing good.
The injections by most people they're utilizing come from aviary products, and they come from the crown of a rooster, okay? We use a different process, and the injection that we use is called Genvest 800, and it does not come from aviary products. It comes from bacteria. It's a little bit more expensive, but we find we get much better results. The patient will receive 5 injections over an 8-week period, along with the physical therapy. And they will receive that physical therapy before we start injections, while we do injections, and afterwards, so that we can increase their mobility and strength. There's another important part to this, and that's bracing, okay? And we utilize bracing, and I'm gonna let Noman talk a little bit about that and how effective it is. But there's a key here. We don't just do one thing or another thing. We do all of these in concert together, and we control the environment. So when that patient comes in, they'll receive the physical therapy in the same environment that they're going to get an injection. They'll receive a bracing fitting and be taught how to use the bracing so it can be more effective for them, all under one roof. The significance of this is we can control the environment so that we can continue to obtain these 86.6 positive outcomes, which is very high, and this is over 10 years and 10,000 patients. So it's a significant element to think about. But I'm going to turn it over to Noman because I have a tendency to talk too much there, and let him talk a little bit about the bracing and emphasize some of the other things. Thank you.
I'm going to back up a little bit. Earlier, you guys were talking about that patient who goes to see orthopedic and want to get surgery, or the implants that you were talking about is not very efficient. Another factor is there are a lot of senior, they want to get knee replacement, but they can't due to their medical condition. They could have cardiac issue, they could have stroke issue, or other medical.
To go through the procedure.
Exactly. Sure. They cannot go under anesthesia and go through the procedure. Then you have another group of senior, they just don't want to get a knee replacement because they have heard the bad outcome about knee replacement.
Or they just don't want to have surgery in general. Exactly. They don't want to go under
Well,
anesthesia.
the other thing, if I can interject,
diabetic.
is that, and I don't have the statistics with me, but maybe sometime when I come back, I'll bring them. But NSAIDs, which are the typical drugs that we get over the counter, such as Advil and ibuprofen, and those have very, very bad side effects when you're using them on a long-term basis there. So when we're utilizing this kind of a process, we can eliminate those situations where we can make things worse than better.
Earlier in the show, one of the other show we were talking that medical history, talking to patient, getting their history, is very important.
Absolutely.
And then we were talking about earlier that when you call the doctor office, it's hard to get a doctor or get a medical record. And that was one of the things before we started the Knee Institute, how we want to put everything under one roof. The physicians are there, the therapists are there, the equipments are there, and we can control. When you talk about controlled environment, that's what we were talking about. When patient comes in, evaluated by physical therapy, a lot of time patient cannot explain you what is wrong. They just come and they tell you I have a knee pain.
Hurts here.
It
Just
hurts
point
here.
to a spot. It's
As
the
a
finger
therapist,
diagnosis.
Exactly.
This.
As a therapist, you have to figure out and a lot of senior who have knee issue, or anybody who has knee issue, last thing they want to do, get up and walk. The more you sit down, you're going to miss the birthday, you're going to miss the grocery, you're going to miss the going to bathroom.
This is what I was pointing out earlier. And you know, the public, they hear just, if a senior falls down and they break their hip, the chances of mortality are great, right? They break the hip, they're immobile. By being immobile, their lungs aren't moving as well, their body's not moving as well, they get sick, they get pneumonia, and they die. No different than compression fracture. We see that just as often as fractured hips. Most people don't hear about that. A compression fracture is a small break in the body of the vertebrae, crushes down, and same thing now, they're immobile, they're rotting away in a chair, they get sick, they get pneumonia, they die.
Correct.
You're absolutely correct, and what we see a lot of is, which falls back into the scope of chiropractic care, is that because one joint area is so discomforting to them, they try to adjust by going to the other that isn't. Okay, so all of a sudden, within a very short period of time, their entire skeletal is out of balance. And when that starts to come, then it creates more and more difficulty in many, many different areas. And we will have a patient come in and be in severe discomfort with their knee, but then they'll start telling us their hip hurts them, their back hurts them, and it's all what I believe partially responsible by overcompensating and putting yourself out of balance, and that's where chiropractic really makes a difference.
And everything moves up the kinetic chain. I mean, an ankle injury can then lead to problems in the knee, to the hip. And that's not just in seniors, that's in an injury. Someone sprains an ankle, they're going to favor one side, and so that's going to cause lots of different problems. And like we're saying with the immobility, no different than if it was a compression fracture or a broken hip, having pain in the knee and chronic constant pain prevents them from moving around, and when seniors aren't moving around, their mortality percentage increases immediately. So it's important to keep good mobilization for their entire structure, their cardiovascular system, for their joints, but having chronic pain prevents that. So something like the procedures, what you guys are doing, is incredible.
And that's part of the Knee Institute, that when patient comes in with a knee pain, because of immobility of a patient over the last 6 months, they're just tight. So we look at the knee as a whole. We look at the hamstring, how flexible the hamstrings are, how flexible your quads and hip flexors are, how tight is your IT band is, or how flexible that is. Once we straighten that knee, and while they're doing the injections, in 8 weeks, you have a very good outcome.
Let's break that down a little bit for our audience here. So you said, when someone has pain in the knee, we're looking at the knee here, right?
Yep.
You said you want to see the flexibility
Of the
and strength
hamstring,
of
which is the
hamstring.
muscles are in the back. Because when you're sitting for a long period of time, what happens, the hamstring, they're attached from your back of the knee all the way to your pelvic area. If you're sitting for a long period of time, they just get too tight. And anytime patient or person trying to get up, when you have tight hamstring, it's going to have a pain in the knee automatically.
And then you mentioned the next muscle, the quadriceps. These are these big muscles that you use to walk, to basically extend the leg, and they actually come around, and the tendon attaches past the knee.
Correct.
The patellar tendon goes underneath there. So a lot of people don't realize the joint has a lot more than just the joint. There's all the musculature around it. So even though the pain is here, some things could be affecting you from the muscles even all the way up to the bone you sit on, the butt bone.
Exactly, and it goes all the way further back in the hip. When you're sitting for a long period of time because your knee hurt, what happens to your hip flexor? They are in the shortened position, they're tight. When you try to get up, you have that flexed posture.
And the iliopsoas muscle is in here too. It actually goes up and attaches to the body of the spine.
Correct.
And so you're affecting all the way up from just
Exactly.
sitting from a long time from
And
your knee.
what else I have seen in the patient, when they come for knee institute, a lot of time, IT band is so tight. And they cannot describe, or nobody, if you're not well, as a therapist, it's part of your job too. When you're evaluating what we did, the protocol, we have put 5, 6 factors that we're going to look.
But as a layman, nobody has any idea. They just point to
Knee.
what they
You know what's
Exactly.
interesting? Let me point this out, as long as he brought that up. We have a patient just recently that Noman is treating, and this particular patient went to a very well-known orthopedic surgeon who told him, there's nothing we can do. He went to Duke to get the IT, which is a very prestigious place, and he has been in tremendous discomfort and immobile. And within about 15 minutes of treatment by Noman, he thought it was a miracle. Okay, now that was a temporary relief, but as we work with him through the whole total process, his knee will be much better, and his flexibility all the way down to his hip will be significantly better. And what amazes me is his orthopedic surgeon said, you just live with the pain.
Just for the record, each patient comes in with their own medical history. Some people have complicated issues, some people are not. Some are easy to fix, some are not.
Right.
And just when we're looking at the knee, we have to look at body as a whole. What happened in the last 10 years? This one patient that you are talking about had some massive hip issue also. So, the result's going to be there 100%? Maybe not. But it's not that we cannot achieve what we're trying to achieve, but you have to look at what other structures are involved.
And it's important when you take a detailed history, when you understand what's going on, you understand the biomechanics and the physiology.
Correct.
That the patient then can understand that too, because some patients think, I want to come in and fix instantly, and it's not going to happen.
And that's the education process, like we were talking, that if you can educate the patient, where we going, how we going to get there, and what it takes to get there.
And steps in between.
Exactly.
As long as they're hitting the milestones like you said, then they understand.
I'll do my best, but you got to go home and do your exercise too to get the good
One
results.
of the things that we do, sort of interesting, we're doing it today, we do it 4 times during the process we do it, and it's a WAC procedure. And what we're actually doing is getting data back from the patient from day 1 to the day that they're discharged, and in between is where was your pain level, 0, no pain, 10, excruciating. Where was your mobility in this particular instance or that instance when you started, and where is it today? It's a very good tool for us to measure where that patient is coming from. Had a patient that was 68 years old, came in with a cane, a little bit overweight. We're working on nutrition with him, and nutrition is important. In the middle of the segment, him and his wife went down to Indiana to Shipshewana, and he left his cane. He walked 2 miles in Shipshewana, Indiana at the fair there without any assistance. He came back, he was just excited like heck. He then finished our program, and he went to China, and he walked the Great Wall. Wow. And he said, I've not been able to do anything like this for over a decade there. That is what this is really all about, and that's what really brings us the most joy, is seeing patients like him. And we have 10s and 20, 30, 40, 50, 60, 100 patients that do the same thing. But I do not want to create an illusion that we get everybody better. But I will come out and factually state, and can back it up, that 87% of the people we see get positive results. And that's very high in comparison to most anything in medicine. So that's exciting.
Absolutely. So let's talk about a little bit more about what the condition is, what osteoarthritis of the knee is. I know we were talking about it a little bit earlier. Maybe we could kind of describe a little bit to our audience, what is osteoarthritis, how do people get it, and why is it more prevalent in seniors?
Yeah, well, it's the weakness of bone, and especially in senior, female tend to have more than male because the estrogen loss in the body. And this is why estrogen therapy is very big in the last 15, 20 years, and it helps the female. Then what's happening when arthritis or osteoarthritis, these are bone issues, what's happening, the bone is kind of body is attacking your own bone.
Now, there's a few types of arthritis. You know, people have heard rheumatoid, that's more chemical. Osteoarthritis is more degenerative.
Correct.
It's just
Aging.
wearing out faster.
Correct.
One way sometimes I'll describe is like, think of a column of door hinges, right? They're all connected, but yet they're all individual. But let's say now I just took a hammer and I just smashed a couple of the hinges, and you open the door thousands of times, which one will rust out first? The one that you had smashed will rust out first. So
Correct.
where you've had the most wear and tear, repetitive trauma,
Hinge joint.
it's going to then wear out faster.
Exactly.
Now, so potentially the knee would wear out faster for someone than the hip.
Hip, exactly.
Some people, the hip may wear out faster than the knee, depending on how they've lived their life. And so we'll even see that in the spine, where I'll take some x-rays on someone, or we'll take our digital motion x-ray, we'll see, you know, it looks like you have degenerative changes at C5 and C6, right? And they'll say, well, I'm getting older, of course I should have it. Well, you don't have it at C2, C3, C4, only where they've had the most wear and tear.
Yeah.
Right? So we see that with, in general, hinge joints are a little easier to wear out than some of the others.
Correct.
And you'll see in patients as we age, the synovial fluid, which is the fluid, these are your two bones, and the patella, which is your kneecap, are out here. Synovial fluid begins to dry up, and the cartilage begins to dry up, and it starts to break off, and you have little pieces called osteoids that float around, and that's part of the problem that I had there. And so when we do those injections in there, what really happens is it acts like a shock absorber, and it will then create just a gel kind of substance, and will create that cushion for them, so that eliminates the receptors from making you feel like you're having pain there. It smooths out the bone, and also what it does is it gives you more mobility.
Common understanding, like when you go see a doctor, orthopedic x-rays, first thing you learn, bone on bone. What's happening, your top bone is touching the bottom bone. In real life or in nature, we have meniscus that give us a cushion, fluid around there.
Like a shock absorber.
Exactly. So what happened over time when you're talking about degenerative joint or arthritis or osteoarthritis, this cushion stuff that we're looking at under the x-rays is kind of wearing out. So when you stand up and put a full weight on it, bones are touching the other bones. And when bones start to deteriorate, if you look at the top surface under the microscope, it looks like a Velcro. If you can understand the surface of Velcro, and when you put bone on bone, arthritis people usually complain about bone pain in the morning. It's one of the reasons when you're sleeping all night, you don't have that weight bearing. You create little space. But when you get up first thing, when these bones trying to touch the other bone, you hear, not just hear, you will have a lot of pain. Not hear it, but you feel the pain. And what we're trying to do, the injection, they're putting into place and smoothing out those Velcro kind of surface to make it more frictionless. When you get up and put a full weight bearing on it, it has more cushion to it. It's not like meniscus repairing, but it's act like that. And that's what it causes, the decrease in pain. When you have decrease in pain, then you can do 10 other things.
And how long, once someone goes through the protocol, how long typically would it last
I'm
before
so
it starts to wear again?
I'm so happy you asked that question, because it's asked all the time. Generally speaking, it will last anywhere from 6 months to life there. Medicare thinks so highly of this that they will allow a patient every 6 months plus 1 day to come back and have the same
Have it
procedure
again.
done.
Same knee
Okay.
or
Same knee.
Same
Correct.
knee.
Yeah.
The reason they do that, it is significantly less expensive to them in comparison to a knee surgery. But I also want to mention is that I've had personal experience with what Noman has been describing. When my MRI came out, and the doctor looked at it, he said, I don't even know why you're here. You should be getting surgery. I was bone to bone, as he said, okay. I had a torn meniscus, okay. And no wonder I couldn't walk, hardly. No wonder I couldn't get out of a chair. And now I don't have that problem at all there. But it will last anywhere from 6 months to life. Now there's another alternative, which maybe we can discuss at a later time, that we also do, and that's stem cell replacement. And that's a whole new discussion we can talk about later.
Maybe some other show.
But I will tell you that the majority of the patients that do this get results. Now, the orthopedic surgeons cannot do surgery unless they can show the patient has had failure in some way. So they'll write a prescription for them to go to physical therapy, and that's it, and they generally will not succeed as well as they should. Or they'll write a prescription for them to do visco supplementation, which is partially what we do, and they fail. Maybe a third success. They want that failure so that that will give them the opportunity to do surgery. But if you utilize all the tools that are available to us in medicine, you don't have a failure.
I educate patient, surgery definitely, if a surgeon telling you that you need a surgery, go for it. But you should have some other alternative approach to that procedure.
Yeah, the more you try first, certainly the better. Absolutely.
In the end, you're going to get surgery.
Right,
so
right.
if
Doesn't
you give
hurt
yourself,
to give it a try.
exactly.
Yeah,
If
exactly.
you give yourself,
we say the
8
same
week
thing with our patients with spine or
exactly.
whatever as
And
well.
one of the things
doesn't
that
hurt to try.
Yeah.
Can still have the
You're
surgery.
right. One of the things I want to point out too, this is really important, and I'm a crazy Go Blue fan, is that Bo Schemberger used to always say the team, the team, the team. And that's what we're all about, is a team. We have all these different modalities, but more important, we have a team of specialists that all work together under one roof. And I think that that is one of the major reasons that we get this 86.6% success rate that nobody else is getting. So I do want to point out that the team is important, and we all work hard for the same goal. So we have a physical therapist, we have a physician, we have nurse practitioners, we have a chiropractor we're working with, such as yourself. It's a team approach and a team result, and that's why those results are so high.
Absolutely.
Very good.
Well, thank you guys so much for joining us.
Thank you.
We have Bob Willard
Noman Siddiqui,
and
thank
Noman
you.
Siddiqui from the Knee Institute, and we will see everyone next time on Ask the Chiropractor. Stay healthy, and this is Dr. Adam Rodnick out of Commerce Township. We'll see you next time.